Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lillie Shockney.
Hi, this is Lillie Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. No one can argue that the world the last 6 months has upended our lives. The disproportionate number of Black and Latino deaths caused by COVID-19 created an awareness of health disparities among these communities. Today, we are joined by Cheri Wilson, Education and Training Manager for Johns Hopkins Medicine's Office of Diversity, Inclusion, and Health Equity. We will be discussing the role that unconscious bias may play in medicine. So welcome, Cheri.
Great. Thank you, Lillie. For our listening audience, think of what comes to mind when you hear the word bias. For many, the word has a negative connotation, where you may think of such terms as preconceived notions, stereotypes, prejudices, unfounded beliefs, and the like. In actuality, bias is neither positive nor negative, it's neutral. It basically comes down to preferences. However, it's one thing to have a preference for, say, Coke over Pepsi. It's a completely different situation if someone is serving on an admissions or search committee and prefers candidates from certain colleges and universities, or those who are trained by certain programs, or even referred by certain mentors, to the exclusion of equally as qualified candidates. Or what about a provider who doesn't want to serve patients who come from a variety of cultures and languages, because the assumption is that these patients don't follow advice, are viewed as difficult, and are assumed to be non-compliant or non-adherent to treatment recommendations? We define bias as a tendency or inclination that results in judgment without question. It's an automatic response that is a shortcut for how we navigate our world. We typically talk about two types of bias: unconscious bias, also known as implicit bias, and you might have also heard it referred to as hidden, intrinsic, inherent, or even internal bias. And then there's conscious bias, also known as explicit bias. Let's talk a little bit about both of these. Unconscious bias involves mental associations that occur without our awareness, intention, or control. Our associations are influenced by the lenses that we use to view the world, which we learn based upon our backgrounds, inputs, exposures, experiences, and society as a whole. If I asked you to close your eyes and picture a CEO, think of the image that would come to mind. What if I asked you to close your eyes and picture a doctor? What image would come to mind then? Let's take this a step further. If you typed either one of these terms into your favorite search engine, think Google, Bing, Yahoo, what images would appear? There are algorithms that are created by human beings whose unconscious biases find their way into the algorithms that they create. What's important to note is that these associations often conflict with our conscious attitudes, behaviors, and intentions. For example, a person may have a colleague who is known as an advocate for people who are homeless, and every Saturday, you would find this person volunteering in a soup kitchen, working with people who are homeless. This person considers people who are homeless to be their tribe, and this work is their calling. One day, you observe your colleague interacting with a patient who you would perceive to be homeless. Because you know that your colleague is an advocate for people who are homeless, you are positive that this patient-provider encounter will go well. You are shocked, though, when your colleague is short, curt, and downright disrespectful to this patient. This is completely unlike your colleague. Later that day, you pull your colleague aside and ask, what happened? It's very likely that your colleague hasn't given the interaction another thought. When you share what you observed, your colleague's initial response is to get defensive and not to be appreciative of your feedback. Later, your colleague engages in some self-reflection and introspection and thinks about where their ideas about people who are homeless might have come from. In hindsight, your colleague realizes that perhaps they were unaware of unconscious bias that they had towards people who were homeless, despite their volunteer work. So now let's turn to conscious bias. This involves preferences of which we are aware. For instance, a person may be aware of a preference for working with people from their own culture or with people their own age, rather than, say, younger employees. However, conscious bias is often expressed as isms, such as racism, sexism, ableism, heterosexism, colorism, classism, and anti-Semitism. or even phobias such as homophobia, transphobia, xenophobia, which is fear of the other, as well as Islamophobia. While bias is often directed towards individuals based upon their race or ethnicity, bias may exist towards any social group, such as age, gender, gender identity, physical abilities, religion, sexual orientation, weight, national origin, socioeconomic status, or any other characteristic.
This is very interesting, and I don't think it's something that we consciously, ironically enough, think about, but we manifest it, we demonstrate it in the way in which we behave. And bias can be in favor or against one thing, one person, or a group. I know that I have seen differences in behaviors towards individuals based on their age, also their physical abilities, their religion, as you mentioned, sexual orientation, even their weight. And that's, I think, a pretty big issue when we look at the United States population, that there are many individuals that would be classified medically as being obese, and they may be, quite frankly, treated differently as a result of that. It's interesting also to note that not all bias is explicit. So we're not thinking about this in that way, and that it can be implicit. And I suppose in order to have a complete understanding of the unconscious bias, we need to understand how structural and institutional racism can manifest itself and its roles in the workforce diversity.
Sure. Let me first start by discussing unconscious bias as it relates to hiring. And boy, you already started talking about some of the topics I'm going to address. Let's start with names. When someone's looking at resumes, certain names for them may trigger assumptions about people. So we had a study, the Chicago resume study, and what it did, it took resumes that were completely identical experiences, education. The only difference was the name. And the study is called Are Lakeisha and Jamal as Employable as Emily and Brennan? They sent out these resumes, and what they found is that no, Lakeisha and Jamal simply were not receiving those callbacks, and people thought it was largely based upon their name. Well, a similar study was done in Canada, and what it found was that if you had a last name that was Chinese, Pakistani, or Indian, you too were less likely to be called for an interview. How many times have we heard someone say after interviewing someone, yeah, I didn't hire that person because I didn't think they were a good fit, right? That's company culture. And when I hear people say that, I press them on that. I ask, well, what do you mean by a good fit? And you might notice that oftentimes people don't have a good answer for that. I think oftentimes we're looking for clones of ourselves, right? And I got to tell you, having clones of myself in the workplace would be boring, and we wouldn't be a very productive team. I have my own skill set and experiences. I need people from a variety of perspectives. And so that's what makes us wonderful. That good fit thing can be another form of unconscious bias. You mentioned age. Oh my goodness. Yes, that's a huge area. In HR speak, age discrimination actually starts at age 40. And we see this especially disproportionately affects women. If you're in your late 50s and early 60s and you're a woman who gets downsized, it is extremely difficult to get another job. We also see this, look at newscasters. What happens to female newscasters when they reach a certain age? Don't you see them cycling off the air? Oh, she's not as appealing to our demographic, right? Mm-hmm. But the man could be, 80, right? He's still on the air. No one cares. So an interesting way this plays out, there was a male newscaster who was tired of seeing some of the unconscious bias directed towards his female colleagues. And you know what he did? He actually wore the same suit every day for a year. And would you believe it? No one noticed. Because people aren't focusing on the male newscaster. They're more so focusing on the appearance of the female newscaster. Have you ever watched a show and you're like, wow, I thought she was wearing this other outfit before the commercial break, and they do a quick change because it's not appealing to the demographic. No one ever does that to men. Here's another interesting one, applicant pool composition. So when women are only 25% or fewer of an applicant pool for a job, women are less likely to be hired because the assumption is that women aren't qualified because they didn't apply in great numbers to that position. Then we have social media biases. Many of us are on social media all the time. And I'm not talking about the things we tell our kids not to post, those inappropriate photos and stuff. No, this is all that stuff I can't ask you during an interview. I could look at your Facebook, your Instagram, your Twitter, whatever you're using, and I could look and say, oh, she has young children. Oh, I don't want to hire someone with children. Oh, she's caring for an elder. I don't like that political affiliation or religious affiliation, all kinds of things. And I can't ask any of those questions during the interview, but something about that turns me off, and I hold that against you, and you might not get the job. You rightfully mentioned people who are overweight and obese. So from a hiring perspective, and I'm going to talk about it a little bit later from a medical care perspective, but from a hiring perspective, applicants who are overweight and obese are less likely to be hired. And if you're an employee who is overweight or obese, you are more likely to be fired, less likely to be promoted, and less likely to be the face of the organization. They've even done secret shopper studies where they have a so-called normal weight person sitting next to the overweight or obese applicant, and the negative stereotypes about the overweight or obese person spills over to them as well. And they too are less likely to be called back. So despite our country, as you mentioned, becoming more overweight and obese yearly, there's so much stigma associated with being overweight and obese. Those with criminal records. Some may not be aware that if you basically have a felony or a misdemeanor, this can keep you from being employed. You might notice on applications, there's that question. Have you been convicted, right, of a misdemeanor or a felony? Well, what happens is once you have a felony, there's something called felony disenfranchisement, where you, one, might not be able to be getting a job, might not be able to get supplemental food assistance, low-income housing. In some states, you can't vote, and the list goes on and on and on. So the cards are stacked against you. And so then when you come out and you can't succeed and perhaps you end up back in the system, we blame you, even though we've taken all your rights away. What some places have done, so on federal hiring forms, contracting forms, even the Common App for college applications, since we're in college application season, they've removed that box. It's called Ban the Box. But from an unconscious bias perspective, what we found is that despite removing that box, Black men with college degrees who do not have criminal records are still less likely to be hired than white men with high school diplomas or less who actually have criminal records. Because the assumption is that, Black male, he must have a criminal record. Remember at the beginning, I mentioned we are driven, we learn these stereotypes based upon what we're exposed to, our media stereotypes. You can see how that would come into play. And then those with poor credit histories. If people have applied for a job, they might recall that as part of the background process, we're able to authorize a credit report. But think about, what do we think of people who have poor credit histories? Things like, that person doesn't manage money well, that person lives beyond their means, they're irresponsible, but
not reliable.
Not reliable, exactly. Does anyone know what is the number one reason for bankruptcy in the United States today?
I think it's the co-payments and deductibles for healthcare, quite frankly.
You're absolutely correct, Lillie. That is correct. Medical expenses. So think about this. You're someone who's had a catastrophic illness, or you're caring for a loved one with a catastrophic illness, which means maybe they had to quit their job. You have to reduce your hours or quit your job. And now we're going to hold it against you, which is terrible, because the idea is that perhaps you're going to embezzle from the company because you have a poor credit history.
Pregnancy.
Oh, yes.
You talk about the hiring individuals.
Yes, it's very, very difficult to get a job when a woman is pregnant, because the assumption is, she's going to have that baby. She's not going to come back to work. And in general, that is an unconscious bias against women as a whole. You've probably heard employers say, hiring managers, I don't want to hire a woman. She's just going to get married, have kids, right?
Yes.
In fact, it's not too long ago in our history where women teachers, for example, had to quit their jobs when they became pregnant. Even though we say, women should stay home with children, it's a great thing, when they want to come back into the workplace, there is a lot of unconscious bias against them. So that's an excellent point. Those with accents. Honestly, every single one of us has an accent, but people might say, well, wait a minute, is that person from Brooklyn? Is that Boston? Baltimore even? We have accents here, right? But despite that person's credentials, we might hold it against the person. And then foreign accents, that's a whole nother thing. One study has shown that if you have a foreign accent, you're considered less believable, less credible. So I'm not going to hire you. And then a whole nother area is those with disabilities. And disabilities can be both visible and invisible. I will give an example that those on the autism spectrum, one study found that 90% of people on the autism spectrum who would like to work are unable to find employment because of the bias against people with disabilities. And think about if you have an invisible disability. As we age, any one of us could get a disability. Or basically, if you're someone who is suffering from cancer or an autoimmune disorder like lupus, any number of things, it's very difficult to get a job. My last point, I'm going to put a little asterisk next to it, and it's those who are on the LGBTQ plus spectrum. So this is lesbian, gay, bisexual, transgender, queer, questioning plus. Up until June 15th, did you know that someone could be fired simply because they were on that spectrum?
No.
We had no federal protections for people who were on the LGBTQ plus spectrum when it came to employment. So we had a landmark Supreme Court case on June 15th of 2020 that finally banned discrimination against LGBTQ plus workers. So I want to turn now, though, you mentioned both structural and institutional racism. So by setting up that unconscious bias piece, you can see how this feeds into the racism piece. When people hear the word racism, they typically are thinking of interpersonal or personally mediated racism. And so those are those individual racist acts and microaggressions that are carried out from one person to another, such as the use of racial and ethnic slurs or displaying symbols meant to intimidate, such as swastikas, Confederate flags, nooses, KKK flyers, etc. However, we go beyond this to also discuss, as you mentioned, structural or systemic, institutionalized, as well as internalized racism as well. Structural or systemic racism has been part of U.S. history since its founding, actually, since its first Africans were brought to U.S. soil in 1619, or the past 401 years.
Wow.
This involves U.S. society upholding racist policies and practices, which adversely impact racial and ethnic minority groups, such as slavery or annihilation of indigenous peoples, or even the internment of Japanese Americans in camps during World War II. We see structural or systemic racism demonstrated in a variety of areas, such as the wealth gap or lack of generational wealth, employment, education, housing discrimination, government surveillance, things like stop and frisk policies, mass incarceration. So if we think back to the war on drugs in the 80s, there were vastly different sentencing guidelines for possessing crack cocaine, which is predominantly what Black people would have, versus powder cocaine. And so the sentences were much lighter for powder cocaine. Drug arrests overall, immigration policy. And from a healthcare perspective, infant mortality as it relates to Black infants, and then our maternal morbidity and mortality crisis, which is adversely affecting Black and African American women, as well as Indigenous women, and also things like voter disenfranchisement. Now, what's interesting is we have to note that these problems did not go away with the end of slavery or even the signing of the Civil Rights Act of 1964. And these are ongoing issues that need to be addressed. But institutionalized racism, that's pretty much policies and practices that are in our own organizations that reinforce racist standards. Something as simple as hair. For example, dress codes that uphold European beauty standards and forbid the wearing of hairstyles such as natural hair or braids or dreads or locks or twists. You might have heard of candidates not being hired as the result of this standard, or children being suspended from school, or even there was a valedictorian who was denied the opportunity to address their graduating class because of their hairstyle. And one of the most egregious cases, and it's so sad, in the last year or so, there was a New Jersey high school wrestler who literally during the match, he was told that if the referee was not allowed to shave his head in that moment, he would have to forfeit his match, which would have resulted in his high school team losing in this championship. Can you imagine how humiliating that would be? Right?
Wow.
And no one stood up on his behalf. Everyone said, oh, he took one for the team. So they literally shaved his head right before his match. Despite that, he ended up winning his match. But wow, that's just unheard of. And what's sad about that policy is that he had wrestled all season with no other issues. From a workforce diversity perspective, we see that while many organizations appear to be diverse on the surface, when you examine the data further, we see that certain racial and ethnic groups are relegated to the lowest levels of the organization. And the higher you rise in an organization, the fewer members are of racial and ethnic minority groups. That's from a staff perspective. But what about from a faculty and trainee perspective? So we start talking about our medical and graduate students or our residents and our fellows, as well as the healthcare professions as a whole. Sadly, often our institutions don't reflect the populations and communities we serve. For example, the 1910 Flexner Report, which professionalized medical schools, and on the one hand, that's great, it actually resulted in the closure of all but 2 Black medical schools. Due to a segregated educational system, Blacks weren't able to be admitted to predominantly white medical schools, and we still see this today in the low percentage of Black doctors in the U.S., especially Black male doctors. We've made very little progress in the last 20 and 30 years. Lastly, I'll briefly address internalized racism, and this involves the subtle and overt messages that reinforce negative beliefs and self-hatred in individuals. And if you're interested in learning more, I highly recommend that you visit our office's website. It's www.hopkinsmedicine.org/diversity. We have a whole section entitled Racial Discussion Resources. And so you mentioned what was going on this winter and spring. We have a whole document that provides context for the 2020 civic unrest with links for people to learn more. We have support resources for Black individuals and communities. We even have tips for managers in the workplace. And we also have, for those who really want to learn more, suggested readings, documentaries, movies, short film clips, as well as even podcasts.
Let's talk a little bit more about the medical faculty, because I think that we certainly do have a very diverse population of physicians, researchers, nurses, and other medical staff. However, I know that, because I've discussed this before with the scheduling office, that when a patient is calling in to get a new appointment with a doctor that they've never seen, but very much need that specialty, whether it be a new diagnosis of cancer or diabetes or whatever that it may be, that the new patient may say, read me the names of the doctors that are in that specialty that I can select from. And so they'll read, John Smith and Mary Jones, and then they'll get to a name that's a little more complicated to say. And when all is said and done, the patient will say, well, I want Bob Smith or Mary Jones. Whereas ironically, what I encourage is you need to trust Johns Hopkins, right? You need to trust our institution in having excellent faculty in all of our specialties and not be selecting someone or not selecting someone because of the sound of their name and then assumptions made about their race and their ethnicity. However, I will say that I have seen patients have difficulty communicating because of what you mentioned about an accent. So you've got a Baltimore accent going on with a different foreign accent, and the two may not be communicating very well. That's where I think that I always want a family member to come with a patient, a nurse navigator to be present to help with this, to make sure that what is being said is really understood going in both directions, certainly. And anyone who's doing scheduling, whether it be at Johns Hopkins or someplace else, really does need to have a course on exactly what you're describing today so that they're empowered to know how to react to someone who may be demonstrating conscious bias, and that they also know how to help a patient in selecting someone, because it should be based on their specialty. If we've got, as I said, 5 doctors that are in the endocrinology field, this patient is newly diagnosed with diabetes. 2 of them specialize in diabetes, the other specialize in thyroid disease. Then let's focus on the need, right? This patient needs a specialist in the disorder that she now has been diagnosed with. In my example, it would be diabetes. Can we talk a little bit, and can you explain microaggressions a little bit more?
Absolutely. And I'm so glad that you mentioned that, Lillie, because I and one of my colleagues, April Lugo, in our Office of Diversity, Inclusion, and Health Equity, just this spring, we did training on how to collect socio-demographic data, so race, ethnicity, and language, with the schedulers, central schedulers, as well as Johns Hopkins community physicians. And this exact topic came up. So thank you so much. So what we were telling people is, number one, many people don't know that as of March 1st, we have a new policy called Prohibiting Discrimination by Patients Against Employees. It's partially addressing what you're talking about. I don't want that provider because I don't want to take any particular group here. And so, yes, when someone's calling up, unless they've specifically looked in our provider directory ahead of time and, okay, I'm a Nepali patient, I'm from Nepal, and I want someone who speaks Nepali, and this particular doctor indicates that, and I asked for that person by name, that's very different from exactly what you shared. Like, oh no, I don't want that doctor because it's not John Smith. Not knowing, going back to the name thing, John Smith could actually be Asian Indian, and I wouldn't know it because, we could be led astray very easily by name. So what we are encouraging is exactly what you said, is all of our Johns Hopkins faculty, staff are well qualified. And look, the next available appointment is with Dr. So-and-so. Would you like that next available appointment? Okay, great. And then saying, look, we do not discriminate based upon any of these protected classes. And as you said, there can be communication barriers, whether it's a Baltimore accent with someone who has a foreign accent, or if we take it a step further, someone who doesn't speak English at all. And so I gave the example of the Nepali doctor. We would have to make sure that person actually had been tested and had a badge that said that they were qualified bilingual staff. But it's different if someone's selecting for that reason. And there's some other cultural considerations as well. For example, if I am someone who is perhaps an Orthodox Jewish woman or a Muslim man, and you're not supposed to be seen by someone of the opposite sex, that's very different from, I don't want that physician because that physician's overweight, or a certain age, or a certain race, or, oh, that person's gay, I don't want them. And that is what you talked about, conscious bias or discrimination, frankly. But to microaggressions, that's a whole nother area. Basically, we define microaggressions as these brief and subtle comments, behaviors, or even environmental cues that communicate hostile, derogatory, or unwelcoming messages towards members of underrepresented groups. They are experienced frequently and persistently, and although they're not usually ill-intended, they do impact the target negatively. And often they're informed by stereotypes and biases. And there are just so many different examples, and I'll share just a handful. And I'm going to be honest, every single one of us has committed a microaggression, and we've all experienced a microaggression. And so I'm actually going to give us some tips too for how do we address it, because oftentimes people don't know what to do in the moment. We have all been asked, and probably asked someone, where are you from? And on the surface, that's pretty innocuous, right? However, if I go in for the deep dive and someone says, I'm from Baltimore, and I don't believe them, I go, no, where are you really from? Really? Why is that my business? Or where were you born? Or you speak good English. That's pretty much telling that person you don't believe what they said. I need to get that 23andMe Ancestry.com background. You're not from around here. Perhaps it's even sending the message of you're not welcome and you don't belong. So we really need to rethink that one. And you can't look at someone either and tell, oh yeah, that person was born here versus not, because you just really don't know. Or many, many well-meaning people say things like, there's only one race, the human race, or when I look at you, I don't see color. So what that does, and I know that's many well-meaning people trying to say, I treat everyone the same, I'm not going to hold it against you. But what the message it's sending is that basically it's denying a person of color's racial and ethnic experiences. And it's not the act of noticing one's color that's bad. It's what you do with that information. Studies have shown that children from an early age notice skin color differences. That's not bad. But I invite our listeners to Google or go on YouTube and look up the doll test. And you might have heard of this one, Lillie, where in the 1940s, there was a husband and wife psychology team. Basically, what they did is they took a white doll, and there weren't many black dolls. They took a white doll and had to paint it brown. And they asked young children, which doll did you prefer? And overwhelmingly, everyone preferred the white doll. Well, they took it a step further and they asked, can you describe the dolls? Well, the white doll was pretty and smart, and the black doll was ugly and stupid, unfortunately. Well, the reason why I can't use these video clips in any of my trainings is it's both gut-wrenching and disheartening. When they ask the black children, which doll do you look like? You can see the little wheels spinning, because if I've just described this black doll as ugly and stupid, if I say I'm black, and I look like the black doll, does that mean I'm ugly and stupid too? It's just very difficult to watch. And then they've replicated this. And that study was actually very instrumental in the Brown versus Board of Education, the desegregation of schools, 1954. They've replicated this worldwide, Lillie. And sadly, everywhere they do this test, everyone prefers the white doll. And remember I said, where do we get our lenses from? Think about what we as a society are telling young children about the color black, right?
Yes.
When I think of the color black, I can think of one instance where it's a positive, financial, right? You want to be in the black, not in the red. But you look at movies, the villain walks in wearing black, right? That person has a black cloud following them. Beware of black cats. I mean, we're not sending positive imagery, so it's no wonder that people think this. When people say they don't see color, they're basically denying all of this that I just mentioned. Or telling a person of color that they are so articulate, or, you speak so well. So I will say, as a black woman, I have had people say, oh, you're a great presenter. That's one thing. But to say you're so articulate, well, you would think that I'm pretty highly educated. Wouldn't you think I'd be articulate? I want to issue...
As if that was a surprise.
Exactly, right? Yes, I'm an exception, right? It's unusual for someone of your race to be so intelligent. I'd like to issue a little challenge to our listeners, and this one's kind of interesting. If you watch sports at all, next time you're listening to interviews with black athletes, count how many times they're referred to as articulate, And then when you're listening to interviews of white athletes, count how many times they're referred to as articulate. Very rarely are white athletes referred to as articulate. But for Black athletes, it's something you hear time and time again. And then even with language, there's more of an emphasis on physical prowess, athleticism versus the intelligence, versus with white athletes, it's very much so, oh, this person has a great head for the game. Now, those are just a couple of examples of microaggressions, but what do we do about them? And I have to say that oftentimes we really are at a loss for what to do. If you're the one who actually committed a microaggression, we ask people, if you recognize it in the moment, apologize. If you don't recognize it until later, well, at that point, apologize. Now, if someone points out to you that you're the one who has committed a microaggression, what is human nature? It's to get defensive, right? And
Yeah.
so basically, we need to listen with an open mind and think about why what you did was a microaggression, and also think about, where did I get my ideas about this group of people from? So that's one way to address it if you committed it. Now, if you witness a microaggression, we are really pushing on allyship. It's so important for others who hear the microaggression to speak up. There's that saying, silence is complicity, right? If someone's saying something or doing something inappropriate and no one else says something, that person's going to think, oh, it's okay. No one else has a problem with it, right?
Yes.
Basically, what we're asking people to do is you can interrupt the behavior by saying things like, ouch, or basically naming the offense by asking questions like, are you saying what I think you're saying? Or did you really mean? And that might stop the person from doing it. And the reason why we want to rely upon allies is we don't want the person in the targeted group, the one person in the group, to have to speak up for themselves. So if it's a gay slur, don't ask the one gay person to call it out, because think back to the defensiveness. They're going to flip it back on that. Oh, of course you'd say that because you're the one gay person. But if someone who's not gay says something, I think it's going to go a much longer way. We also want to support others who are speaking up. And also, too, you could also talk privately with the offender later on. And then what happens if you are the recipient of a microaggression? Well, due to power differentials, people may choose to speak up or not. I mean, if this is your immediate boss or supervisor, you're not going to speak up, right? You might be afraid of retaliation. My promotion depends on it. My evaluation, right? That's why that allyship piece is so important.
Getting my vacation days approved.
Right. Absolutely. Right. So that's where you might have to rely upon allies. So for those of us who are in positions of power, it is so important that we speak up on behalf of others who cannot. If it's something, though, particularly egregious, yeah, you might consider filing a complaint. And it can be helpful to seek out a community of support, others who might have experienced the same thing. How did you handle it? And finding out what they did to get through that process. Now, you did mention something. This was about people who are overweight and obese. I wanted to go back to that point, though,
yes,
because we talk about provider-patient bias and patient-provider bias. So we talked a little bit about that patient-provider piece when we were talking about scheduling an appointment. I wanted to just touch a little bit more upon the provider-patient bias because, again, it goes both ways. Something as simple as who gets called doctor. Any of our female doctors who are listening, think about the last time you walked into a patient room and you were assumed to be the nurse, right? Or if it's a man who's a nurse who walks into a room, that person's assumed to be a doctor. Or if you're a person of color who's a doctor, let's layer it on here, and you walk in and you're assumed to be the housekeeper or the tech, right? All of those things kind of happen. Also, we see that there is so much bias against patients who are overweight and obese. There's a lot of negative stereotyping and really an assumption that patients who are overweight and obese aren't going to be compliant. And when someone goes in with a legitimate health concern, instead of addressing that concern, it's oftentimes just about if you lost more weight, you'd be fine. I'm going to give an example that I just read about in the past month. It was so sad. There was a patient who was overweight, and she went to her doctor a few times complaining about a growth that she thought she had on her neck. Well, the doctor didn't take her seriously. He basically said, oh, what are you talking about? You just have a fatty neck. It's no big deal. Well, Lillie, sadly, what happened is she did go for a second opinion, so I'll say thankfully. And it turned out, no, she didn't have a fatty neck. It turned out she actually had a stage 4 lymphoma.
Oh, dear.
Had that doctor listened to her concern and not just focused on her weight, maybe she would have had an earlier diagnosis and maybe even a better prognosis. These are all different ways that bias can show up in healthcare, whether it's pain management. And I'd be remiss, this month happens to be Sickle Cell Awareness Month. So we know that sickle cell patients, when they present to the emergency department, oftentimes they don't receive good pain management because they're assumed to be exhibiting drug-seeking behavior and their concerns are not taken seriously. So much work that we need to do.
What can we do as an individual to learn more about actually assessing our own bias or absence thereof, and how can we learn techniques to change our own behaviors?
Absolutely. Unconscious bias is such a hot topic these days. One thing I would suggest is that there is something called the implicit association test or Project Implicit. These are tests that were put together by researchers from Harvard, University of Virginia, University of Washington. So if you Google either IAT or Project Implicit, basically what they are, these are tests that show where there is a gap between our conscious mind and our unconscious mind. These are time tests. You have to use 2 fingers. And what they do, they started off with race. So what you had to do was be able to distinguish, is this a black face or a white face? And you would have to literally black, white, pretty easy. Then you had to associate good with the white face and bad with the black face. Where it tripped people up is they flipped this, and now you had to associate good with the black face and bad with the white face. And remember I said, where do we get our inputs from? The longer it takes you to have to think about something, maybe you're thinking about it because that's not the first thought that came to mind. So what happens is you have to do it very quickly because we don't have lots of minutes to decide whether something's good or bad. And it gives you a response where it says you have some sort of preference. So it could be strong preference, slight, moderate for this group over another group. It's not saying that anyone's a racist or an ageist or take anything like that, but it's giving you an idea that, I didn't realize that potentially I have some sort of unconscious bias against this group. And the purpose of it is for self-education, self-awareness, so that maybe the next time I'm in that situation, I might actually pause and think like, oh, wait a minute. If it's that I have some sort of preference for younger people and I've looked at my team and I don't have anyone over the age of 40, maybe that's an indication I have some sort of unconscious bias. So maybe now as you're reviewing applications or you walk in and your patient is 60 and over, you'll think about that and it might change your behavior. So that's one thing we can do.
That's great. Mm-hmm.
Some other things is I wanted to share 6 strategies or ways that we can mitigate bias. And it's both in our personal lives, in the workplace, as well as in medicine. The first thing is recognizing and accepting that every single one of us has bias. Even I do. I do this work and I'm probably more cognizant of it because of the work that I do. But then next, what we need to do is when we leave certain interactions, we need to be introspective, self-reflect, develop that flashlight to shine upon ourselves to figure out why did I behave in that manner? And then we need to practice constructive uncertainty, meaning turning our exclamation points, meaning I'm positive that this is all I need to know about this person in 7 seconds when I walk into that patient room, to questioning like, oh yes, I know this person isn't dressed well, but that doesn't necessarily mean the person's uninsured. And then getting through that. And then exploring awkwardness and discomfort. So it goes back to kind of what I just mentioned with those implicit association tests, right? Trying to figure out where do we have our unconscious biases. And I'm going to say it is not at all comfortable to find that out. No one wants to know they have bias, but we can't overcome and address it if we're unaware of it. Another way is to engage with people you consider others and expose yourself to positive role models in that group. If we don't have a lot of experience with certain groups of people, we're going to be guided by stereotypes that we've learned. But to break some of those stereotypes by interacting with people, that can go a long way. And I'll give a quick example. During the month of Ramadan, in my county, we have one mosque. And at the end of Ramadan, they have a community iftar or a breaking of the fast. And they invite people in. And it's a fantastic opportunity. Now, for me, I've gone for a couple of years. I know the imam, but I actually heard some community members who I'm guessing don't have much exposure to people who are Muslim. I actually heard people say, wow, they're just like us. Well, when I heard that, you know what that meant for me, Lillie, is they're probably getting their images from what's on TV, what's in film, and sitting across the table from someone breaking bread was going to go a long way in maybe breaking down those assumptions and stereotypes. So maybe in the next time they call and make an appointment, I don't know, they might not be as uncertain about requesting that doctor who they guess or assume is Muslim based upon a name.
Yeah.
And then lastly is getting feedback, meaning no one's walking around asking, am I biased? But really just asking your friends, having an accountability partner. Have you noticed anything? Did I react a certain way in that situation? Is there anything I might be missing? So basically just some key takeaways about bias is that every single one of us has it. And really, honestly, it originated from that whole friend or foe. Think of that fight or flight. Our ancestors had to quickly determine, is this thing safe or is it going to harm me? And if they made the wrong decision, we wouldn't be doing this podcast, Lillie. We wouldn't be here.
Right.
Also, We navigate the world based upon our own lenses, and our lenses are impacted by everything we've been exposed to growing up. And then lastly, we heavily rely upon our biases when we're busy, when we're distracted, and when it's an emergency situation. In fact, studies have shown it reduces our IQ by almost 20 points when we're in those situations. So it's no wonder our decision-making is impacted. And then lastly, because we are individuals working in organizations, we bring our individual biases to those organizations. So we need to notice where there is bias, recognize it, slow down, and pause so we can make more objective decisions.
Thank you so much. Before we close, Cheri, I want to actually tell you a short story about my grandson. He's almost 14, but when he was 5 and my granddaughter was 3, I was visiting at their house. We were out in the yard playing, and a man came to deliver big slabs of slate because my daughter and son-in-law were going to make a patio. And my grandson ran in the house and got 2 construction helmets to protect himself and his little sister, which I thought was funny, from these things coming out of this man's truck 30 feet away. But the man wanted to engage in a discussion with Brendan, because Brendan said, "Hi, I'm Brendan. This is my sister, Kira." And she said, "Hi, beware of sharks in the grass." Where that came from, we don't know. The man said, "When I'm not delivering these things are in the back of my truck, I'm a volunteer fireman. I bet when you grow up, Brendan, you would like to be a fireman." And Brendan thought, and he said, no. And he said, "Oh, then you want to be a policeman." He thought again, no. "I bet you want to be a doctor." "No." "Well, what do you want to be?" And that child said, "I still want to be a Brendan." And I thought, this is the first step of this discussion that you and I are having. And I thought that was incredible.
Wow.
I just thought that was incredible.
So powerful. That is so powerful, because everything that came out of his mouth, my goodness, was a piece of unconscious bias. He didn't turn to Kira, right, and say, "Do you want to be?" And that goes back to when I said, close your eyes and picture who is a firefighter, who is a police officer, who is a doctor from an early age. And he's now putting onto them unconscious bias. And now maybe they can internalize that. And maybe Kira, who likes the sharks in the grass, so maybe had an affinity for science, right, might not want to become a doctor, because it's not assumed that women are going to become doctors or go into the STEM fields. And so, yes, this shows how this is so embedded in our everyday lives and how powerful it can be.
It certainly is. So thank you very much, Cheri, for taking time out of your day to be part of our Insights That Matter podcast. I know that our listening audience has learned a great deal, and I'm confident that they will start having some introspection and saying, let me think about this for myself. Let me even think about this for my family, and perhaps have a discussion over dinner tonight.
Absolutely. Thank you, Lillie.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, and your host, Lillie Shockney, with a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from HRH Foundation and Keswick Wise and Wellness Center that support our podcast series, Insights That Matter. For more information about A Woman's Journey, visit our website, hopkinsmedicine.org/A Woman's Journey. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/A Woman's Journey. Until next time, stay well.